Okay, so we are here with Professor Stephen Campbell. He was the head of the AUA guideline on renal cell carcinoma. It was in 2017, and now we have just listened from him the updates in that guideline. So I'd like to know, and first of all, thank you very much for being with us. And a very interesting part was about the genetic testing. We know that in prostate we have advanced a lot, but in kidney cancer we're still learning a lot. So what does this guideline brings us, and what shall we do regarding genetic counseling?
Okay, yes. What we're finding now is that familial kidney cancer is much more common than previously appreciated. We now think it represents about 6% of all the patients, but I think as the years go by and we identify additional genes, that figure will go up even higher. The indications for genetic counseling have now been expanded, reflecting all of the progress in the field. So now we are recommending genetic counseling in several different populations. First, any patients with kidney cancer who are 46 years or younger, any patient with multifocal or bilateral kidney cancer, patients with a first-degree relative with a first or second-degree relative with kidney cancer, any patient with a first-degree relative who has a known familial kidney cancer syndrome, even if they've never had a renal cell carcinoma. So these are some of the populations. One other population is that we will quite often do a surgery for kidney cancer, and the final pathology or histology will come back suggestive of like fumarate hydratase mutation or SDH deficient RCC. So whenever the histology or the pathology suggests a familial syndrome, those patients should also undergo genetic counseling.
It's very interesting. And what's your routine at Cleveland Clinic? So how do you manage these patients? Do you order the test, or do you send them to genetic counseling? How does it work?
Well, we're blessed with a really outstanding genetic counseling team at the Cleveland Clinic. In fact, the lead on our team is Dr. Kara Sang, who discovered the PTEN gene, or was on the team that did the work for that. So she has always been a leader in the field of genetic mutations related to kidney cancer. So we just refer them over to her team, and they'll sit down with the patients and get the family history, and they'll help the patient decide which kind of genetic testing that they might do.
And the panels that they do are usually the same, like for prostate cancer, a very wide panel, or are there specific panels that they normally do?
So that's a great question. So one of the things is that we've learned is we don't really do the genetic counseling until after the biopsy or the surgery. Then we know what the histology is. So if it comes back chromophobe, then we're thinking Birt-Hogg-Dubé. If it's coming back clear cell, then we're thinking von Hippel-Lindau or BAP1 deficient. So really, it turns out in kidney cancer, the pathology will quite often guide the testing.
So thank you very much again for your presence here, and all the Brazilians could listen a little bit, and later we'll give you more about these updates on kidney cancer guidelines. Thank you very much.
Okay, thank you. Okay.